Hello everyone, welcome to sqadia.com, and in the third section of our lecture topic, chronic pelvic infection, we will talk about the clinical features and diagnosis of genital tuberculosis. In this section, we will talk about some clinical features, how it presents, how we can investigate, and what's the differential diagnosis of genital tuberculosis. The clinical features of patient with genital tuberculosis is usually, if we look at the patient profile, sometimes it's a family history of tuberculosis is common or is present. So a family history of contact may be available. Always ask the patient if they have some family members, friends, or if where they are working, or they have somebody who have tuberculosis. So history of contact is important. Onset of genital tuberculosis is usually not acute, it's insidious, slow progressing. A flare-up of infection usually occur after the immune system is suppressed. If there is a low immune system, then the latent tuberculin bacillus, which is present in the body already, it flare up and cause acute infection. So a flare-up can also occur after diagnostic endometrial curettage or histosalpingography. So after these procedures, usually the genital tuberculosis can spread or it can occur. Curettage or hysterosalpingography. Salpingography is for the examination of the fallopian tube. So after this procedure, sometimes there is acute flare-up of the tuberculosis. There may be any past history of tubercular infection of the lungs or lymph nodes. Again, besides the family history, patient it might give you the history that she might have a past history of tuberculosis. If treatment was not done completely or not, ask the patient if they had full course for tuberculosis, if it was cured or not. So usually there is a history of previous infection present. The infection is restricted mostly 80% to childbearing period. Usually the 80% of cases are in the reproductive age group. Genital tuberculosis occur 10 to 20% who have pulmonary tuberculosis in adolescence age. So these are all patient features that are associated with the patient profile. Ask the patient about the family history of tuberculosis, ask if they had previous history of tuberculosis. Usually incomplete or inadequate treatment can lead to tuberculosis. If the onset of genital tuberculosis is usually insidious, it's and then 80% of the cases is in the reproductive age, and about 10 to 20% of the patients have previous history of tuberculosis and can be after diagnostic DNCs, dilation and curettage, or histosalpingography. Then what are the symptoms of the patient with genital tuberculosis? There is weakness. Weakness is very, very common. Patients with tuberculosis, usually they have a chronic history of cough. Sometimes they complain of low-grade fever present, especially in the evening. They are weak, they are pale, and they don't have any energy. They do little work and they feel like shortness of breath and restlessness, and they keep on lying from here and there. So weakness is common. Then there is low-grade fever. Anorexia. Anorexia is loss of appetite. They don't eat very well also. Menstrual abnormality is also present. All menstrual abnormality is also due to sometimes due to weakness or low hemoglobin level or anemia. Constitutional symptoms include all these: weakness, pallor, tiredness, malaise, anorexia, constitutional symptoms. Then there is anemia. Night sweats. Night sweats are also very common. Infertility. Chronic pelvic pain is present also. And there is vaginal discharge. So all these are very common symptoms associated with pelvic or genital tuberculosis because it's a chronic infection. Patient is weak, pale, there is pain, tenderness, discomfort, anorexia, menstrual abnormality, vaginal discharge, and night sweat. Investigations done is for tuberculosis. There is blood test done. In blood test, we have Montague's test, chest X-ray, diagnostic curating of the uterus to find out the test done on the endometrium of the uterus. Then nucleic acid amplification test. First day menstrual discharge, lymph node biopsy, sputum and urine test, and then again biopsy and histosalpingography. This is the test done on the fallopian tube. Histosalpingography, a dye is injected and then the fallopian tubes are studied if there are any adhesions, scarring, narrowing of the fallopian tube. Chest X-ray is very, very common test done in the diagnosis of tuberculosis. If primary tuberculosis is suspected, the chest X-ray is done. And usually the picture of tuberculosis is very, very clear on the chest X-ray. Even the patient have a past history of tuberculosis, chest X-ray is sometimes very helpful because it shows the old lesions and old scars on the chest X-ray. And then on the blood test, usually the hemoglobin level is tested and complete blood count is done, ESR is done. So all these tests can give the idea if the hemoglobin is low in anemia, if there is leukocytosis or increased white blood cell count, if there is increase in ESR, all these are indicative of infections. Montague's test is especially done for tuberculosis, in which the PPD, purified protein derivative, is injected intradermally and the test is performed. So all these are the sputum and urine. Urinalysis is done, but again, sputum test is also very important in patients who have pulmonary tuberculosis or primary tuberculosis. Give a bottle to the patient and tell them that early in the morning they should try to, after drinking a small amount of water, they should cough deep and then collect the sputum that comes out into the small container and bring it to the lab for the culture of the mycobacterium. So again, all these tests are very important for the investigation of the patient with the tuberculosis. Imaging studies, in which we have MRI and CT scans of different organs of the body. Laparoscopy, in which the direct visualization can be done by the laparoscope. So again, as I mentioned, in the blood testing, we do leukocyte count, ESR. Leukocyte count is the count of white blood cell. ESR is the erythrocyte sedimentation rate. This is the diagram of diagnostic uterine curettage called D and C, dilation and curettage. The position in which the patient should be is called lithotomy position. Lithotomy, patient is lying on the back with feet in the stirrups. These are the stirrups. And then in lithotomy position, speculum is inserted inside the vagina, and then the dilator, this is the dilator. The opening of the cervix is dilated with the help of dilator, so it should be less painful. Cervix is dilated, and then the curettage is inserted into the uterus, and the curating is done with the help of curate, and that curate, the endometrium lining that is removed with the help of curettage is sent to the lab for the biopsy or examination. So this is the these are the 3 steps for D and C, or dilation and curettage. It's a diagnostic procedure because the specimen sent to the lab for examination gives the exact diagnosis versus the abnormality. So the position is lithotomy, dilators, and then we have the curettage. This is the picture of histosalpingography. As I mentioned, hysterosalpingogram, the dye is injected, and then we can take the picture of the flow of the dye to the different structures. So histosalpingogram, this is the histosalpingogram that shows marked extravasation of dye in venous and lymphatic channels. Here you can see it's the extravasation. Dye is coming out after the picture is taken. Histosalpingogram. This is all the dye coming out. Proved to be a case of tubercular endometritis. This is the picture of tubercular endometritis. And this is the histosalpingogram, which shows you the beaded appearance of the tube with variable filling. Beaded appearance. Here you can see the beaded appearance of the tube. This is again later on pelvic tuberculosis was confirmed. So these are the 2 pictures of histosalpingograms, and histosalpingography is performed in which dye is injected, and then the picture is taken. In the one you can easily see dye coming out here, and then this is the beaded appearance of the fallopian tube. Next, the diagnosis. Diagnosis, the physician should be conscious of the entity. One should suspect and exclude genital tuberculosis in the following condition. If these conditions are present, then one should suspect of genital tuberculosis. If there is unexplained infertility or amenorrhea, absence of menstruation, if there is recurrent episode of pelvic infections not responding to usual antibiotic therapy, suspect it might be genital tuberculosis present. If there is presence of pelvic mass with nodules in the pouch of Douglas, if nodules are present in pouch of Douglas. Differential diagnosis is the pelvic mass is often confused with. If there is pelvic mass present, these are the differential diagnoses which the physician should suspect. Pyogenic tubo-ovarian mass. If there is tubo-ovarian mass which is pyogenic, pus containing. If there is endometriosis, If there is ovarian cyst present, this is the diagram of or ultrasound of the ovarian cysts. Cysts are fluid-filled sacs present in the ovaries, adherent, attached to the ovaries. If there is chronic disturbed ectopic pregnancy, this is here. So these are all the differential diagnoses of the pelvic masses. It can be tubo-ovarian mass, pyogenic, tubo-ovarian abscess also. Pelvic endometriosis is the presence of endometrium outside the uterus. If there is any adherent ovarian cyst present, or it can be ectopic pregnancy, which is disturbed or complicated. So all these are the differential diagnosis of the pelvic mass. Here ovarian cyst, this is the diagram of the ovarian cyst. Here again ovarian abnormalities here, endometriosis. Okay, so that was all about the diagnosis, differential diagnosis and tests performed for the diagnosis of the genital tuberculosis. Thanks for watching sqadia.com.